The treatment of ovarian cancer with rucaparib campsylate, also known as Rubraca by Alicia Sierra, Alyssa, and Mackenzie. So the basic cancer research will begin with what is ovarian cancer? It first invades the ovaries, which are almond-sized female reproductive organs that produce ova and hormones. Their tumor types are epithelial, stromal, and dermal. Epithelial is the most common, and they begin in cells that coat the ovary. Stromal tumors begin in cells that produce hormones. Dermal tumors begin in cells that produce ova, and other related diseases are ovarian cysts. First, they invade the ovaries. This begins with healthy ovaries, and the early stage cancer first begins with growth on one or multiple ovaries, and then the late stage cancer is taking over the entire ovary. Our tumor types are epithelial, which first begin in simple cuboidal or low pseudostratified columnar cells. Then we move on to stromal, which is rare to have a tumor in your stromal cells. And these cells are connective tissue that bind the structures together. Germal or thecal cells are the endocrine cells associated with ovarian follicles. They're divided into grades and types. Grades focuses more on their appearance. So grade 1 looks like normal tissue and therefore has a positive prognosis, where grade 3 doesn't look like normal tissue anymore and they have a worse prognosis. Types are described by their speed, symptoms, and response to therapy. Type 1 grows very slowly, doesn't have a lot of symptoms, and does not respond well to chemo, where type 2 grows quickly and they do respond to chemo. Epithelial malignant tumors, we have serous, clear cell, mucinous, and endometrioid. Serous has high and low grades, and it is responsive to therapy. It has a bilateral, smaller, and less hypercalcemia appearance. Clear cell is resistive. It's related to endometriosis, and it has a unilateral, larger, and more hypercalcemia appearance. Mucinous is more resistive to therapy and has increased levels of CA19-9. Endometrioid typically is diagnosed early. It has a low grade and it's related to endometriosis. Stromal malignant tumors, we have granulosa cells, granulosa theca, and Stertoli Leydig. Granulosa cells are also known as sex cord stromal tumors. They have increased estrogen levels and have symptoms that depend on the menstrual cycle. Granulosa theca comes in two flavors, juvenile and adult, and their typical symptoms include abdominal pain, and you can feel the mass. Stertoli Leydig is common in young women, and their common symptom is virilization. Germal tumors, we have teratoma immature, which cannot be differentiated from the mature. So if the mature is confused with the immature, the mature is benign. So if there is a confusion between them two and they go in with surgery to remove it, but it turns out it can be immature, which is malignant, then you have potential spread of the cancer, and that's a danger to the patient. The dysgerminomas do respond well to therapy, and endodermal sinus germ tumors, also known as a yolk sac tumor, respond well to therapy. Lastly, we have ovarian cysts, which are common, and they come in two flavors, the corpus luteum, and they typically present no symptoms, and they go away by themselves. The mature teratoma, as I've previously mentioned, is benign, but it can appear with multiple cell types because it arises from embryonic cells.
TP53 is a common tumor suppressor gene that is associated with ovarian cancer. The function of this gene is that it encodes a nuclear phosphoprotein that binds DNA. It's a negative regulator of cell growth. It's also a negative regulator of proliferation after DNA damage occurs, and it signals apoptosis. Some of the hallmarks that are associated with a mutation in TP53 include evading growth suppression, which is associated with it actually being a tumor suppressor gene. When there's a mutation in this tumor suppressor gene, it essentially cuts it off, and so the cells are able to evade the suppression of growth, resisting cell death. So if there are not proper signals for apoptosis, the cells will not die, which is a hallmark. And also genome instability and mutations. This is important because the inactivation of the TP53 gene or the disruption of the protein product is thought to allow the persistence of damaged DNA and the possible development of malignant cells, which could then turn into a tumor. Some of the consequences of the mutation is that, like previously stated, it allows damaged DNA to continue to multiply, and the loss of the p53 pathway. The p53 pathway is known as the guardian of the genome. It does a lot of the protecting and ensuring that all DNA is being produced as it should be, and also just extra mutations can be associated with amino acids if there is a TP53 mutation. So most TP53 germline mutations are common missense mutations in the DNA bonding domain of p53. When mutated, TP53 often results in a production of altered amino acids. Studies have found that all families with TP53 mutations have at least one family member with a sarcoma or cancer. TP53 is also associated with LFS, which is a syndrome that is clinically and genetically heterogeneous, and it's an autosomal dominant disorder. So it completely results in a loss of the p53 pathway. There's also a significant increase in the risk of cancer for female carriers of the mutated TP53 gene, which is a result of the loss of heterozygosity.
Intervention of Rubraca. Rubraca is a PARP inhibitor, and that means it prevents the repair of single-stranded DNA. And we're introduced with the topic of synthetic lethality, which occurs when the PARP inhibitor and mutated DNA can no longer repair damaged DNA, and the cell is forced to undergo apoptosis. The hallmark we identified was evading growth suppression, and the proto-oncogene we identified was c-Myc, which is responsible for metabolism and growth, and it's highly overexpressed. This is just a picture to depict the mechanism. So we have the damaged DNA cancer cells, and Rubraca comes in and prevents the repair of single-stranded DNA, forcing the cell to undergo apoptosis when it tries to replicate.
So these are the definitions of epidemiology. We'll be focusing on the cancer epidemiology definition for this. Ovarian cancer, this is just showing some statistics throughout the United States. Ovarian cancer is ranked 17th out of the most common types of cancer in the US. On the left, you can see out of all the types of cancers, ovarian cancer ranks at 1.1% out of all the new cancer cases in the US. This shows ovarian cancer throughout North Carolina. Ovarian cancer is ranked 5 out of 10 for top cancers in North Carolina. That's on average about 378 deaths per year. So who's getting ovarian cancer? This is by race and ethnicity. As you can see, white women have the highest rate out of all diagnoses. Out of all other ethnicities, they rank about 12 to 13 new diagnoses per 100,000 people. This is by age group of who's getting ovarian cancer. So women between the ages of 55 to 64 years old have the highest rate of new ovarian cancer. You can see that's the tallest bar on the graph, ranking at about 24.4 of new diagnoses. This is showing the survival rates for a per 5-year relative survival rate. So that means how many people survive 5 years or more after being diagnosed with ovarian cancer. On the left, you can see this is all SEER stages. So that means surveillance, epidemiology, and end results. This is through different types of ovarian cancer. On the right, here's the focus of the third bullet of germ cell tumors of the ovary per SEER stage. So localized is there's no sign that the cancer is spread outside the ovaries. Regional, The cancer is spread outside the ovaries to nearby structures. Distant, the cancer is spread to distant part of the body. So, and then all stages is 93% overall survival rate per that 5-year period. So these numbers they only apply to the stage of cancer when it's first diagnosed. So it doesn't really take into account that cancer grows and could come back and all other things. So these numbers are relative. These are some graphs showing this 5-year relative survival. So on the left is each stage percentage. And then these people over here on the top is the gray figures represent those who have died from ovarian cancer, and the green figures represent those who have survived 5 years or more. And overall, it's a 49.1% survival rate per that 5-year, which is not the best, but not the worst. On the bottom here is how they measure these 5-year survival rates. So it's observed all-cause survival and the net cancer-specific survival and the crude probability of death. These are all statistics taken into accountability to make this percentage number. These are some more graphs representing this 5-year period. So on the left here, you can see, as I said before, the age range of 50 to 64 is the highest. They have the highest chance of getting ovarian cancer. So they rank at a 54.4% 5-year relative survival. And then on the right here, you can see that linearly it's increasing. The survival rate is increasing. So that means in turn that the mortality and incidence rates, which is new cases, is decreasing since survival is increasing. So it's relative. These are some risk factors associated with ovarian cancer. So all of these on this page represent in the epithelial cells specifically, and that's the most common ovarian cancer. So that's why I focused on that. Risk factors are just something that affects your chances of getting the disease. So age, overweight, these are certain risk factors of ovarian cancer. On the right here, the starred bullet is hereditary breast and ovarian cancer syndrome. This is the risk factor that I'm going to focus on in this slide. So the HBOC is a syndrome where you have, it's an inherited cancer. So you're predisposed to getting ovarian cancer. It could be in your family's history. Your family history has a history of cancer. You are more likely to have this syndrome. So this syndrome is a mutation in either the BRCA1 or BRCA2 gene. And these are, as we learned, these are tumor suppressor genes which regulate cell growth. This is a germline mutation, which is in the body's reproductive cells, which makes sense because the ovaries. So the HBOC syndrome is actually the most common cause of hereditary breast and ovarian cancer in all ethnic and racial backgrounds. So that is just why I chose this, because it's a very prevalent risk factor. On the right here, you can see these are risk percentages if you have the syndrome of getting ovarian cancer, and below that is the treatment. So it's very individualized because the types of cancer and the tumor size is very specific to each person. Genetic testing and counseling are 2 treatment options for the syndrome, and we'll focus on the Rubraca. So this is a study. This article is the FDA's approval of the rucaparib drug for this treating this BRCA mutation. So the study was 106 patients. Mean age is that highest age, like I said before, the 50 to 64 years old. And this ORR statistic stands for the objective response rate. So for the BRCA1 and BRCA2, they rank at 54%, and the confidence interval is between 41 and 66 and 37 to 70. On the right here is the safety portion of approving this drug. So they did 377 patients taking at least one 600 milligram dose of the rucaparib, and the results show that the FDA center actually approved the Foundation Focus, this device with they're combining the device with the rucaparib for the detection of the BRCA1 and BRCA2 mutations in the DNA. So the device is intended to detect BRCA1 and BRCA2 along with the help of this drug. So this safety profile of the rucaparib is acceptable for this intended population. Only 0.5% of the patients experience the most concerning adverse reactions, so that's why it could be approved. This is the benefit risk analysis portion. So 1 and 1, 2 and 2, they all correlate from left and right. Number 1 is the analysis of the condition. So this ovarian cancer is life-threatening. Like this is a reason we need this drug. Number 2 is the current treatment options. There's no current treatment options for the patients with BRCA gene mutations, so this oral monotherapy of the rucaparib could be beneficial. Number 3 is the benefits. So since this ORR percentage is supporting the effectiveness, it's predicted to provide clinical benefit for this disease. Number 4 is just plain out risk. So the highest adverse reactions is less than 20%. So this is a low number. So the safety is approved. Number 5 is the risk management. So with these, if there are risks, there are ways to combat those. So it's routine and labeling precautions that is manageable. In conclusion, so this drug is beneficial because it's likely to predict clinical benefit from those safety and experiments from that article. The safety profile is acceptable and there's toxicity alternatives. Like I said before, there's other ways to combat those adverse reactions. The benefit risk profile overall is favorable to support the accelerated approval of the rucaparib as a monotherapy for the treatment of patients with this BRCA mutation that is associated with ovarian cancer.
Okay, I'm going to proceed the presentation into clinical cancer research. So first of all, the clinical subtypes of ovarian cancer, there's more than 10 histological subtypes, and I could go into depth about the other ones, but I'm going to focus on the main 90%, which begin in epithelial cells and are known as epithelial ovarian cancer. The main 4 subtypes of that kind of cancer are serous, endometrioid, clear cell, and mucinous, and they are classified based on their histological subtype because ovarian cancer in general is just a heterogeneous group of neoplasms. And then the other 10% of ovarian cancers are cancers that arise in the germ cells, which are precursors to egg cells, or granulosa cells, which are hormone-producing ovarian cells. So prognosis, there's several different prognoses for different types of ovarian cancer. However, focusing on stage 1 to 4 for invasive epithelial ovarian cancer, it goes from a 90% survival rate at stage 1 to a 17% survival rate at stage 4, so decreasing as the stage increases. The propensity to spread, you have cancers that begin in the ovaries, fallopian tubes, and peritoneum, and these are all very similar. So it's easily spread from one structure to another because of that similarity. And then if the ovarian cancer does become metastatic and spreads throughout the body, it typically forms cancerous tumors in the abdominal cavity or on nearby organs such as bladder or colon, and it does that on the surface of those organs. So when someone is diagnosed with ovarian cancer, obviously treatments can vary based on the patient and their cancer, but the most common treatment protocol for ovarian cancer is to start with a debulking surgery followed by 6 rounds of chemotherapy and go from there. In terms of the patient experience of someone with ovarian cancer, you're going to experience fatigue, weakness, nausea, vomiting, constipation, edema, and then some things that are typically signs of if you're experiencing many of these symptoms. Ovarian cancer is definitely a possibility. Abdominal bloating, swelling, quickly feeling full when eating, weight loss, discomfort to the pelvic area, fatigue, back pain, change in bowel habits, or a frequent need to urinate. And then we've already talked about the serous, endometrioid, mucinous, clear cell, or squamous clinical histological subtypes of ovarian cancer. And then ovarian cancer is also classified into high and low grade, and then early or late advanced stage cancer. And it is more difficult to treat the epithelial or the ovarian cancers that originate in the germ or granulosa cells as opposed to the epithelial cells, which have more treatments available. And then high-grade tumors and advanced cancers are more difficult to treat as opposed to early and low-grade tumors. And that remains true with ovarian cancer. In terms of resistance, chemotherapy is an effective treatment for women when they're first diagnosed with ovarian cancer, but 70 to 90% of cases will reoccur due to drug resistance. And that remains true for our targeted therapy, Rubraca, or by its scientific name, rucaparib campsylate. So it's a targeted therapy, so it is susceptible to resistance, and it is a PARP inhibitor, meaning that it blocks the activity of PARP enzyme, which helps to repair DNA damage in cancer cells. So those cancer cells are unable to repair that damage, and that prevents them from growing. And then you can check out this infographic to get more information just about how evident ovarian cancer is, the effects on women in the US, and the treatments and reoccurrence for that. So side effects that a patient can expect to experience obviously vary. There's many, they go from mild to serious, but the serious ones that we're going to focus on are going to be basically in terms of your blood. So your low blood count, platelets or low blood counts of white blood cells, red blood cells, and also bone marrow or bone cancers. And then also there's a possibility of acute myeloid leukemia, which is a cancer of the white blood cells. And this drug is used for cancers related to ovarian cancer. And we use it as a maintenance therapy in adults with recurrent cancer who have a complete or partial response to platinum therapy, which is just the coordination complexes of platinum that are chemotherapeutic agents. And then we also use it with adults with certain germline or somatic mutations in their BRCA1 and 2 genes who have already been treated with 2 other types of chemotherapy. Some drug interactions of Rubraca. There are many drugs that probably should not be used with Rubraca, and a physician would definitely tell you that and recommend you against it, caution you towards it. But drugs that should never be used with Rubraca are the following, starting with finerenone and ending with volcosporin. I'm not going to butcher all of those names, but you can see them there, and these drugs should absolutely not be used with Rubraca as serious consequences would occur. Recommended dose for Rubraca is 600 milligrams, which is you would take 2 300 milligram tablets orally twice a day without food or with food for a total of 1,200 milligrams a day. And this would vary based on the patient and their prescription. And then just a little bit into the scientific name of Rubraca, which is rubicrib campsylate. Campsylate salt form of rubicrib is a PARP inhibitor, and we have rubicrib campsylate being a camphor sulfonate obtained by a reaction with rubicrib. That is all. Thank you for listening, and these are our citations. We hope that you learned more about ovarian cancer and Rubraca.